Okay, welcome to our final broadcast for today. It is January, let's go south just a quarter inch. January 17, 2023, that's too much, quarter inch. I said a quarter inch, you went about an inch. All right, that's good. Let's see if we can wag in. I'm going to be doing a surgery now on a patient who has a known infection of the disc and bone at L4-5. He got this infection at another facility, and they've done everything they can to help him. However, the infection was not responding initially to IV antibiotics, and now he's on IV antibiotics still. And we're going to go in and clean out as much of this infection as we can. So I've got to see the sacrum really nicely. That's why I wanted you south a quarter inch with your base. There you go. That's perfect. All right. Love it. So we're heading right for that L4-5 disc, transforaminal. So far, so good. He's doing great. He's comfortable. There we go. Shot. So I've swung around the facet. Now let's get an AP. So this patient went to another center, not ours, up in Virginia, and had a discogram procedure done, diagnostic. That's perfect. That discogram unfortunately infected his disc because it was dirty. They did a dirty procedure. I'm not going to lie about it. It's really what happened. And now he's dealing with an infected disc, infected spine, discitis, osteomyelitis. And as I said, I normally don't help people with infections by other doctors, but it was a special request and from a nurse that I know, and I felt that we could help him. So that's why we're doing his surgery. And the way we're going to help him, are you okay? We're ready for him to be awake. Shut. I could feel the herniation right there. So, ooh, that disc is tough. And what I mean by tough is fibrotic, okay? That's what happens when you have an infection and chronic inflammation. You get a fibrotic disc. Let's see, shot. So we could do a discogram. I don't feel that it's necessary. We'll probably put a little bit of dye. I don't want to put too much because I don't want to flush anything out. I want to keep it contained, but it will be helpful to be able to see. Shot? Yeah, there it is. Very good. That should be enough. All right. So we're going to go in there and we're going to take some samples. We know the material is infected, but I want to send it off to the lab because he's been getting antibiotics now for quite some time. So we want to know, is there still infection? And if there is, what's causing it? Are you guys ready with the tubes? Because we're going to have samples pretty soon, probably in the next 10 minutes. Now, do we have antibiotics in the irrigation? No. Good. All right, I'm making an incision, 7 millimeters. The whole surgery will be done through this tiny little cut. I'm going to bring the dilator down. Now he has another bad disc at L5S1. We're not going to deal with it today because he has an infection at L4-5. And if I try to fix the L5S1 disc, he's going to end up getting an infection there too. And we don't want to spread the infection. Sure. Let's give him a little numbing medicine right now. Some Novocaine. Now I know his little daughter may be watching his surgery with his wife. I think they're in Puerto Rico. And his daughter's name is Georgianne. And I just met her. Sweet girl. Your daddy's going to be fine. I'm taking good care of him. So there's some numbing medicine there. Shot. Now I'm going to go past the facet joint into the disc. Shot. Yep. Can feel the herniation. It's pretty firm. Very firm. Okay, very, very firm. And the reason you get a very firm herniation is lots of inflammation. And of course, infections cause just that. Do you need him a little more sedated, or? Yeah, that is tough. You're doing great. Very firm disc. Take it out. Now you can feel the chronic inflammation getting in there. Of course, inflammation that's chronic is anything that is longer than about 6 weeks. In healthcare, in medicine, we call it chronic. So here we go. Are you on?
Yeah.
Let me see. Good? Yeah. We have to advance the tube. There it is. It's advancing. Good. All right, we're dead center. We want to get some samples now, endoscopically. So let's get everything ready. Go ahead and take the fluoro out. I'll take care of this if you can get the sample stuff ready. Now I'm going to use the pituitary. I'm going to grab multiple samples. I'm going to hand them to you. I want you to put them, but also in the,
I got it.
also in the, what do you call it?
The bucket?
Inside the aerobic, anaerobic, and fungal cultures. Okay. All right, here we go. We're in the infected disc at L4-5. And now we're going to go down and see what's going on inside this, what's called discitis. Oh my God, I'm so sorry, Luis. I didn't know it was on. Just squirted Luis in the face. All right, here we go. All right, so I expect there to be more inflammation. So far, it looks pretty good. Why would there be more inflammation? Well, simply because he has an infection in his disc. This is all potentially infected material. So I'm going to take some biopsies and we're going to send them off to the lab and see if he's growing anything still. I need you to get a 11 blade and take those pieces out with the 11 blade. Use the 11 blade. Uh-huh. There you go. Let's get some more. Now, all this is herniation, staining blue because it's herniated. And I would just use your Raytech like you normally do. You're losing all your sample. Okay? There's still a piece there. Raytech. Okay. Just take the Raytech pieces and put them on.
Yeah. Got a good blood pressure.
Good. We've got about 15 minutes maximum. We'll be done. All right, I'm going to bring the laser. We've gotten several samples of tissue. We're going to put those in that. I want some of them in here.
Yes, sir.
And I want some of them not in there.
No problem.
And I'll see if I can get more samples.
Okay.
But let's start bringing the laser in. We're going to blast this infection. Perfect. Now, just for reference, the diameter of the laser fiber is 1 millimeter. In case you were wondering. A lot of scar tissue. A lot more than we normally see with just a herniated disc. And see all that stranding? That's all signs of granulation tissue or healing there. Okay. Looks pretty good. Looks like there's areas like this right here that don't look so good that I'm lasering. And there's areas that look like they're healing. So we're going to do a debridement of the tear like we normally would. For those of you who watch my surgeries all the time, just see what kind of differences you can notice about this particular disc, right? See all the pink granulation tissue down there? You don't normally see that. That's a sign of excessive heavy inflammation. See it right down there? Nothing wrong with that stuff. It's just healing. Okay, there's some more herniation. Now my goal for this disc is A, clear the infection. First of all, A, get it, diagnostic tissue. B, clear the infection. And C, get rid of his back pain that comes from this particular disc. He's got 2 bad discs. We're only fixing the infected one today. Let's see the grabber. The tissue is very firm. The herniation itself is very firm. By the way, Luis, you can also grab little pieces of herniation. Ooh, it is so tough. Like those right there, you need?
Yeah.
You can get those later too and send them off for culture.
Yes, sir.
Yeah. But you got to harvest them before we use the betadine. Look at all the calcium deposits in this disc. Now I don't know if those are a result of the infection and inflammation or long-standing degenerative disc disease. We do see them often, and obviously in our non-infected discs. All right. Here we go. There's the tear right there. You guys see the annular tear? The white is the annulus on both sides, and the blue is the herniation sitting in the tear. So he went to Johns Hopkins University to get a diagnosis of the infection and start his antibiotic treatment. And I don't blame him. He wanted to go what he thought was the best. But Johns Hopkins doesn't know how to do this type of surgery we're doing. So the actual debridement had to be done here at Duke Spine. And that's why we're doing it. Now if you're an aspiring surgeon and you ever confronted with infections that you have to deal with, look at the tear. You guys see that? As I wiggle it, you see the tear? You see the herniation stuck in the tear? So this was his primary problem. If he would have come here initially, he wouldn't have an infection and we would have no more back pain. We would have fixed him right away. This is the source of his back pain right there. So this is the part of the surgery where we're treating his chronic back pain and leg pain that came from this disc. And we're debriding at the same time. Any questions from our audience?
Yes, we do. This comes from JMC on YouTube.
All right, JMC.
And they asked, what are your thoughts on traction for spine pain relief? And is it safe for psoriatic spondylitis patients?
What are my thoughts on traction for spine pain relief? And is it safe for psoriatic spondylitis patients?
Correct.
Yes, it's safe for psoriatic spondylitis patients, number one. Does it work? I don't think it gives lasting relief. I don't think traction is going to give you lasting relief at all. I don't think it's harmful. I think it's safe. You can do it. I just don't think you're going to be getting great results. But to be honest with you, the other results for other treatments are so bad that, traction results will probably be comparable. And, that way you can avoid a lot of other types of invasive treatment. The only surgery that may actually work is the Duke laser disc repair, what we're doing right now, which is a debridement of your arthritic joint that's causing pain, specifically the disc. But to answer your question, I think it's safe and I think it's okay. I just don't expect it's going to work. All right, we got 5 minutes left. So we're not going to take questions at the end of the surgery today. We're going to take them now. So if you have questions, feel free to type them up. Happy to answer them for you. You can see this is the annular tear. It's heavily scarred from the infection. Oh, there's the source of his back pain right there. The pink stuff, it's granulation tissue. Just about done with his debridement. And I'm removing what's called devitalized tissue. So whenever you do a debridement as a surgeon, you want to remove devitalized tissue. Devitalized tissue is, it's like a foreign body. It doesn't have a blood supply. And it's just going to get infected and stay infected. And all this wad of scar tissue right here, this is all dead tissue. So scar tissue doesn't have really a good blood supply. That's why it's white. And granulation tissue has a lot of blood supply. And that pink stuff is also the source of his back pain. So we had to get rid of that. But this right here is tissue that I think is harboring infection. It's keeping the infection. So this is going to be helpful getting rid of it. And the laser does such a good job. There's no surgical instrument that would do a better job than the laser. All right.
We have a question.
Sure.
This comes from SL Red on YouTube,
Hi, SL Red.
and they ask,
Welcome.
why do people have the TENS unit in their spine?
Why do people have a TENS unit in their spine?
Correct.
Well, I don't think anybody puts a TENS unit in the spine. I think what they're putting is a spinal cord stimulator implanted. And the reason why is that it makes a lot of money for doctors to do that. They generate a lot of profit, but it doesn't really help the patients at all. So it's a very good question. We don't do them. We do probably a few a year, maybe 5 a year. We could do hundreds a year, but we don't because they don't work. The idea is that the spinal cord stimulator is going to send electrical impulses up on a wire that sits on top of your spinal cord in your thoracic spine, and it basically blocks pain signals from going up to your brain. Pain signals travel on a track, a neural track that runs in the back of the spinal cord, and they put those wires right on top of that neural tract and hope that it sends magnetic signals that would block transmission of electrical current through your spinal cord. All right, we're ready.
All right, lights on, please. Thank you.
So at this point, we're going to clean everything out. We're going to put some antibiotics in. Let's put vancomycin. Oh, yeah. We're going to do our betadine first, lots of it. Betadine is a wonderful antiseptic. It kills bacteria quite effectively and fungus. So we're going to let that betadine get in there and just stay in there for a few minutes. Just let it sit in there, killing as much bacteria as possible. A little pressure to keep it in, distribute it. Beautiful. All right. Then we're going to irrigate some of it out, most of it out. You have the vancomycin powder. You know how I'm going to put it in. I'm just going to put it here and just push it down.
Yeah. You want to get more?
Yeah, I need to suck this out. No, he's already on vancomycin. 1.5 grams twice a day. We don't need to give him any more. His body is full of vanc. What is that? Yeah, no. No. All right, we're ready for the powder, vancomycin powder. All right. So you have a funnel? A funnel? You have a sterile piece of paper? Aha. Thank you. Good job. I need a funnel. Do you have this? My hands are too wet. Can we get another piece? Let me have something to dry my hands. You got it, Luis?
I mean, we can try like this.
You got it cone shaped? Coned up? Mm-hmm. All right. Well, let me try putting some of these big chunks. They should break up, right?
Yeah, of course.
So we're gonna pack a little. No, no. We're gonna pack a little vancomycin powder in there. Here, no, no, no. The chunks are gonna work. All right. You grab a chunk, put it there, and I'll plunge it in. Just use your hands. Yeah, that thing won't work. Just put it there, and I'll plunge it in. So we're basically filling the disc, not completely, just a little bit, with antibiotic, vancomycin. And of course, there's still a little residual betadine down there. Oh, it's nice. All right, that should be plenty. All right, that should be plenty. Plenty, plenty, plenty. All right. So we are done. We're going to take this out, a little pressure. Ready? All right, so we're done. We did everything we wanted to do. I got cultures. Whatever you do, do not get the vancomycin on that tissue. You understand what I'm saying?
I understand. Yeah.
So let's send the samples, put those away. Don't get any vancomycin powder on them. Any questions from the audience? Because we're finished. Surgery went well. I achieved everything I wanted to do.
No current questions.
Great. All right, we're going to end the stream. Thanks for watching us and joining us. I wish the best for this patient. Put him in your prayers.